Welcome everybody. Welcome to another episode of PEM Rules. And today we're going to take a little break from the rules, and we'll start at the beginning. We'll start at the approach, or I should say my approach to the pediatric patients in the pediatric emergency department. So start with the end in mind. I think it's important to realize what really are my goals as a pediatric emergency doctor with every patient I see. So essentially in emergency medicine, the way I see it, there are really two goals, two things I have to do with every patient. The first thing, as you kind of know, is acute care. Some people refer to it as the ABC. I need to give the patients what they need. So if the patient is vomiting, maybe some Zofran and fluids. If the patient is in mild pain, ibuprofen, severe pain, morphine, etc. Some people call it the ABC. I don't like that term because really most of the time the ABCs are fine. So I just call it acute care. I need to give the child what they need right now. The second thing I have to do with every patient is really decide the appropriate disposition. Is this something that is representative of some bad etiology or some bad disease and I'm missing something and the kid needs to stay in the hospital? Or is this a mild presentation of whatever and the child is safe to go home? This is a very, very important second goal. Now, to do that, I have to get a good history and do a physical exam. Maybe somewhere in the middle I do some kind of workup, maybe I do not. But essentially, two goals, two tasks with every patient. Acute care and then deciding on the appropriate disposition. So let's talk a little bit about taking history. I always teach the residents, and especially the medical students, in the pediatric emergency medicine, you got to be focused. Not everyone needs a full H&P in the emergency department, especially if the kid is not particularly well appearing. There is a term I call point of care history and physical. Let's say I walk into a room and there's an 80-year-old who's clearly wheezing and in respiratory distress. I ask Mom, does little Johnny have asthma? If she says yes, I take a quick listen, and if I hear wheezing, that's all I need right now. I get my nurse, get the kid started on albuterol, steroids, and get him started on the treatment that he needs. This is not the time to sit down and ask if he's been coughing for 2 days, 3 days, is the cough wet or dry. He has asthma, he's in respiratory distress, he's wheezing, he needs some treatment before everything else. So remember, point of care, history, and physical. Second thing I'd like to make a point of is that history is the most important thing we do for our patients in the pediatric emergency medicine department. It is a key feature in coming to the right conclusion and making the right diagnosis. And I have several examples to demonstrate that. There is nothing more important than taking a good history from a patient. Stay tuned, I'll give you some more examples why the history is so important. Now, the way I go about taking history in the pediatric emergency department is by starting with everything else except for the HPI and then focusing on the HPI right after. Since unlike in the adult emergency department, most patients are healthy, really have very little, if any, past medical history or medications that they take, I find it very helpful to get everything out of the way and then focus on the HPI. So my history taking usually starts with, Mom, does little Johnny have any medical problems? Does he have any diseases he suffers from on a regular basis? Does little Johnny take any medication on a regular basis? Has little Johnny ever been to the hospital for anything serious or surgical? Has little Johnny ever been on antibiotics? I think those questions and hopefully answers kind of encompass everything I need to know about the past medical history, the surgical history, the medication the patient takes in kind of a easy to go about manner, something that the mom will understand very quickly. Now, usually it's a no, because he does not have any medical problem, he does not take any medications, etc. And it kind of allows me to get everything out of the way, and now I can focus on the HPI, which to me is the most important part of the encounter. The next term I want to talk about is something I call digging deeper. Every time I take a history and I get a positive on anything, I dig deeper into that problem or whatever Mom mentioned. For example, if Mom says that little Johnny has had fever for 3 days and she took him to his doctor, great. Mom, what did the doctor say? What did he give you? Did he discharge Johnny on any medications? In other words, I found a positive on my history. Mom took him to the doctor. I therefore have to dig deeper into that positive. I need to find out everything about that patient encounter with his doctor so I can learn what did they think, what medications did they give him, etc. So every time I find a positive on my history, I dig deeper into that positive. The next point is vaccination status. That is a key feature I ask about. I think it's very important to keep in mind, and the data supports that any vaccinated child is extremely protected from serious bacterial infections, namely meningitis, pneumonia, and even otitis media. So knowing if the child is vaccinated is a very, very important feature of the history taking. Now, the last thing I want to mention about history taking is the fact that what has happened to patients in the past tends to happen again and again. If you recall basic medicine, one of the biggest risk factors for pancreatitis is having pancreatitis in the past. One of the biggest risks for suicide attempt is history of a suicide attempt. It's the same thing for so many other things. So patients who tend to do very badly tend to do very badly again and again. Bad asthmatics tend to have bad asthma exacerbations. So I think it's very important to ask about prior experiences, which is why I ask, has the patient ever been to the hospital? Has he get admitted in the past? And this also has to do with the 4 questions of asthma. Anytime I see a child with asthma, I'd like to try to see and find out how bad Johnny's asthma really is. I do that using the 4 questions. Mom, has little Johnny ever been to the emergency room for asthma? If she says yes, I move on. Has he ever needed to be admitted for his asthma? If she says yes, I move on. Then I ask, has he ever been admitted to the ICU for asthma? And if she says yes, I go to the final 4th question. Has little Johnny been intubated for his asthma? A child that says yes for all 4 questions is a child with bad asthma. That's a child I'm going to treat more aggressively. That's a child that if he's borderline admission or discharge, I'm probably going to keep him in. That's a child that I'm going to take a look at more often and document, hopefully, that he's looking better and improving. That's a child with very bad asthma. So what happened to patient in the past tends to happen again and again. Remember that. Now, with regards to the physical exam, which is a very important component of what I do, I must admit, physical exam in the pediatric emergency department, especially on crying babies and kids, is not particularly helpful. I always teach my residents and the medical students that, in my opinion, focusing on the history is much more important. But then again, physical exam is important as well. And physical exam starts with the vital signs. I always a little worried when I see a patient with unexplained tachycardia. And I'll explain what I mean. Obviously, as you know, pediatric patients have a higher heart rate. That is normal. But the heart rate always has to be proportional to the reality of the situation. For example, if the baby is crying and fussy and screaming, I'm okay with him being tachycardic. If the patient is highly febrile and his tachycardia is really high, that's okay. Most febrile illnesses are secondary to viral illness. But I'm always a little weary when I see a pediatric patient with unexplained tachycardia. A kid with, let's say, cough, whose heart rate is 140, but his oxygenation is fine, is not crying, is not coughing right now, and is not running around. Why is he so tachycardic? Am I missing something, namely sepsis or bacterial infection? In that situation, I give some fluids. I want to make sure that the tachycardia resolves. That is unexplained tachycardia. A child who's not fussy, not running around, not hypoxic, and not febrile right now because mom has been giving him Tylenol around the clock, which is fine, should not be that tachycardic. If the patient is very febrile, very tachycardic, but is well appearing, vaccinated, and has a non-focal exam, I'm okay with that. That patient is ready for discharge. The next point on the physical exam is looking. So much can be learned about a child just by looking. A child that is sitting up in bed, smiling and laughing, and has a normal mental status probably does not have meningitis. A child with no increased respiratory effort or respiratory distress, who's speaking in full sentences, is unlikely to have pneumonia. Oftentimes, it's better to look before the child gets upset once you get too close. So looking is a very important part of the physical exam and can be done and should be done the minute you enter the room. Now, medical students out there, hopefully you know the following point. You got to be very opportunistic in your physical exam. If it is a respiratory complaint and the child is quiet, listen to the lungs right now before you look in the ear, make the child cry, and lose your exam. So sometimes when I walk into a room with a child with a respiratory complaint and he's being held by mom quiet, I go, Mom, I'm Dr. Ivan, I'm the supervising doc. Little Johnny is very quiet right now and I know you're worried about his cough. Let me just listen to the lungs before we get started. I think parents often appreciate that, and it helps me take advantage of the situation that little Johnny is quiet right now and I could get a good lung exam. So you got to be very opportunistic. The next point I want to make is something that parents often worry about. Remember, normal child behavior is to cry and be anxious and fussy when a stranger, especially a doctor, touches them. Don't be alarmed by a crying, fussy child. I literally document normal behavior when I see that. I often reassure the parents that although little Johnny is screaming and crying now, that to me is very reassuring. He is responding appropriately to my exam and is responding appropriately to my presence. That is great. I'm a little bit more worried about a child who's completely oblivious to my presence, especially if I look in their ears or do something that is somewhat painful and they're completely out of it. Obviously, that is a lot more concerning. Now, the last point I want to make, and I always have a little bit of a hard time teaching medical students and residents that point, is that some kids just want to come to the ER to avoid school. We have a lot of abdominal pain patients on Monday. Guess why? So it's important to really think about that and keep that in mind and be very distractible in your exam. So, for example, oftentimes when a child comes into the emergency department with abdominal pain, I take my stethoscope and I just say, hey buddy, I'm just going to listen to your stomach. But little do they know, I'm actually pushing with my stethoscope on their abdomen and hopefully getting no response. Once I actually start pushing with my hand, well, guess what? It hurts. So be opportunistic and cheat a little bit. It's okay. Distract them. Talk to them about Pokemon and Power Rangers while you're checking the abdomen or palpating their arm if you're concerned they have a fracture. A child with a fracture is going to scream even if you talk about his favorite topic. Lastly, I want to talk about the workup that I do in the pediatric emergency department. In pediatrics, we try to be very conservative about poking, irradiating, and testing. I think it's very important to remember when thinking about your orders, get the orders that give you an answer. For example, a child with a fever. Dr. Ivan, I'd like to get a CBC. Well, guess what? A CBC is likely to be elevated on a child with fever because he has an infection. A CBC does not tell me where the infection is and if the child needs any specific treatment such as antibiotics. I don't feel that that is a very good test. So I encourage the residents to obtain tests that give you an answer and the answer changes the management. A urine analysis tells you if there's a UTI or no UTI. That translates to antibiotics or no antibiotics. In my mind, that is a good test. Chest x-ray, the same. But a test like CBC really is not particularly helpful. Another good example is the respiratory viral panel, or RVP. Probably has a different name in different hospitals. But essentially, that is a PCR in the nose that tells you which virus the patient has. All those viruses are benign, they all go away, and there is no treatment for any of them. So keeping a child in the emergency room for 2 or 3 hours for a respiratory PCR that tells you which benign viral illness he has, which you can do nothing about, in my mind, is not a very good use of our time. That is not a very good test. So think of the tests that give you an answer, and that answer changes the management. Lastly, I want to talk about something that I find very, very important. Patient or parent reassurance. Remember, we are here for the children, and the children are our patients. However, reassuring a parent is a very important component of what I do. So if I know little Johnny is fine, has a viral illness, and he's safe to go home, but mom does not feel safe going home, there's a lot more to do and discuss. Mom, what exactly were you worried about that Johnny has? And if she says pneumonia, I get an x-ray and prove does not have pneumonia. In my mind, getting an x-ray in order to reassure a mom that child is safe to go home and she does not need to return or seek medical care somewhere else is very important, and it is a very small price to pay. So I do what I have to do in order to reassure parents that the child is safe to go home. Having said that, I think it's important to remember that your primary commitment is to the patient. So personally, I do not reassure parents by getting a CT because that is not fair for the child. I also don't reassure parents by giving antibiotics because, again, that is not fair for the child. So I think it's important to work with the parents and reassure them, but keeping the commitment to the child and not hurting the child. I would argue that CT or antibiotics does exactly that. That is all for today, guys. I hope you find those advice helpful, and I hope you find our episodes interesting. This is Yaron Ivan, Pediatric Emergency Medicine in Orlando, Florida, and I'll see you next time. Have a great day.